of all, thank you for the invitation to come. It's really a great pleasure to talk to surgeons who are out there in the field, to trainees who are like kind of taking the steps towards doing it, to how to become a better surgeon and how to become a better team member for our patients who are undergoing surgery. I am a colorectal surgeon. I'm called, what day is today? I'm called today. I did a colon and an epi and a and a brief. It wasn't so fun. When we are doing surgery, it is incumbent on us to really figure out what we're doing, kind of look at, am I doing this technique well, treating this patient well? But at the end of the day, when we kind of look back on what we're doing, it's the data that a lot of times tells us how we're doing. And it's sometimes hard to do case by case by case by case, but it is important to do that. So that, like you just heard, are very important. But to look at data is very important. And I tell you all know this, that there's good data and there's bad data. And having accurate data is going to be increasingly important, especially with the wave of technology and AI and all of this stuff. And we get data, you know, this is my lunch, we're going to get data from those types of things. We're going to get data from all over. It's going to come together. And it's going to be really important, especially for the trainers, to understand what is good data, because we are all going to be measured even more than we are. So I'm going to kind of go through, I'm going to talk to you about a registry that we built at the American College of Surgeons called NSQIP, the National Surgical Quality Improvement Program. Most people have heard of NSQIP. A lot of the residents have heard of it. They kind of get the database and they kind of do research on it. But I want to let you know about the steps we took to try to make it as accurate as possible. I'm going to transition to talk about once we have data, how do we still get better? Because the data are one thing, but acting on the data, and then kind of what are some strategies that we use to get better in surgery. Let's start off with this. What's the problem with inaccurate data? So inaccurate data is dangerous for quality and quality improvement because it distorts the magnitude of the effect. So we can think that it's a small problem, it's a big problem. It could change the direction. We could think we were doing well, but we're not doing well. Causality and attribution. So who is responsible for it? And if we don't have a good sense of that, then we would be thinking it's just this group and it's really a larger group. Comparison across units, so benchmarking. When we compare at UCLA ourselves to other institutions like Creighton or Crosstown, or Siemens, if we have bad data, we might think we're better. Time trends. Oh, this is not a problem now. It was a problem long time ago, but it might be a problem now. And really what this does is it creates false confidence. It delays the recognition of harm. It leads to wrong resources, and right now resources are tight, so we don't want to put in the wrong spot. And it erodes trust, and trust is a big thing. We could have a whole long talk about trust in the healthcare system, but if we don't trust what we're doing, we will not engage. So at UCLA, we try to make a quality improvement effort, and people don't trust the data, can't get them to engage, can't get them to own anything, can't get them to do anything, and care stays the way it is. So let me talk a little bit about NSQIP in the background. So it was launched in 2004. And so that's over 20 so years ago. And the primary aim of NSQIP, of the data, was it allows us to know how we're doing. Just like how we're doing. Because before, a lot of times we didn't know how we're doing. We had bad data, so nobody trusted it. We had, you know, bits and pieces of things, but it wasn't kind of put together, so we didn't really know how we're doing. NSQIP came along and said, all right, let's kind of try to do this. Statistics tells us we can get a sample instead of measuring the whole universe, and tells us that we can know how we're doing with a sample. So it was a sample of cases. It was risk adjusted. So every time we have outcomes and every time we put out a report, people call us and say, no, our patients are sicker. This is not fair if we're doing that. So we do risk adjustment, and I'll talk a little bit about that. It's clinical data. So it's data from the record, it's data from the patient, it is not data from billing or codes. I'll talk a little bit about that. the benchmarking, we compare ourselves at UCLA to the other hospitals in Los Angeles. It is risk adjusted. So the whole thing is risk adjusted, and I'll show you about that. It has strict 30-day follow-up. So we measure patients to the time of discharge. Their complication rate is much lower than if we follow it to 7 days after discharge to 30 days after discharge. So we give a much truer view of what a complication rate is to a month out. Specialties, thousands of procedures, 700 hospitals in 15 countries and so forth. That's what NSQIP is. This is my favorite graph of NSQIP. It's what we call a caterpillar plot. So each one of these is a hospital point estimate, the yellow dot, and the up and down line is the confidence interval. And you remember from statistics, if this confidence interval doesn't hit 1 in doing a regression, then it's statistically lower than 1, and it's statistically, these hospitals are doing better than expected. So you can imagine this is a mortality rate or an SSI or pneumonia or readmission or whatnot. The variable can change, but these hospitals are doing better than expected. These hospitals over here are doing worse than expected. It's statistics, it's kind of making all these things, and this is the graph that comes out of this. This single picture is probably the most motivating picture for people to do something. So the people in the red call the college. It eventually gets to me because even though I'm the director, I'm really the complaint department. And they say, you stink, Cliff. Your data are wrong. And I ask them like, well, you gave us the data. Your risk adjustment is wrong. Your statisticians are wrong or whatnot. And I'm going to go through to show you why they are where they are. That's a little in jest, but they just like, well, how do we fix ourselves? Even the hospitals that are doing as expected, so the hospitals that are in the middle, that are not in the red, call us and say, well, there are hospitals in the green. Who are they? What are they doing that we're not doing? So this one picture is the 1,000-word kind of thing. It's like, it really motivates people. So in this program, when we first started, and I was sharing a little bit with others yesterday, that I started my kind of career as a faculty working in my cubicle doing analytics in Los Angeles. And so I was kind of nerdy, and I just wanted to make sure that my boss at the time was like, make sure you do it right. And if it's not right, don't come to me, make sure it's right. And every time I would hand him something like, this is from apparently Kissinger said this a long time ago, when somebody would hand him some work and he would say, is this your best work? And if it wasn't your best, and if somebody said, no, but it's getting there, I just wanted to get your feedback, he would hand it back to them without even looking at it. Give me your best work. And so that was kind of like my boss at Rand would always tell me that, give me your best work. And really, it kind of instilled in me that how do we do things scientifically? How do we do things transparently? Because we're always learning. And our idea at the college at the time of these early years of NSQIP was to put stuff out into print so that people could either like it or hate it, but we would want to know where we stood because we just kind of felt that we could always get better. And so I'm going to share with you some papers of how kind of our thought went. And so not just to kind of say that this is what you should do, but the rigor that goes into data, and that when you see data, what goes into that data. So the data from NSQIP comes from the record. And at the time, we didn't have ChatGPT or whatnot to kind of comb through to summarize and whatnot. We had to have human beings do it. And so what we wanted to do was we wanted to train people to look at the record so that we got, if somebody called it an SSI, we agreed with it or they agreed with our definition. And then if we had 10 hospitals, everyone called the same thing SSI or a pneumonia or whatnot. We wanted to have consistency so we could compare apples and apples and apples and apples instead of apples and oranges and the whole fruit stand. If we couldn't benchmark with the same definition, then we lost the game. So the first thing we did was we studied inter-rater reliability. We knew what the definitions were. If we looked at a record, we knew what the complications we would say are complication and not. But would hospital A, hospital B, hospital C do the same thing? And so we studied that. In the initial years, and so you can see that the purple line are the institutions, the number of institutions doing this QIP. The purple, the lighter purple is the number of institutions we would audit. So very early on, we figured, it would be really, really important to look at records. And the number of charts we looked at is the blue line, that over 1,000 charts a year, we would duplicate in terms of the getting out the data to see if we had inter-rater reliability. We figured that we wanted to have less than 5%, and by year 3, year 4, we were getting pretty much everything down to 5%. These were the worst variables in terms of the inter-rater reliability. So we knew that we were getting apples and apples and apples when we were doing that. So we were pretty pleased that we could do that within 3 years. And every time a new hospital joined, we went through that audit, and we wanted to make sure that the data going in wasn't garbage, right? Garbage in, garbage out. So we wanted to have good stuff going on. Once we had all that data, how do we compare hospitals? And you probably remember from statistics that we do regression analyses, and we put the risk factors on one side to kind of predict something on the other side, and the easiest way to do this is logistic regression. However, there's a problem with logistic regression. It's called clustering. If you have 2 surgeons in a hospital, they're more likely to have similar results because of the hospital effect rather than 2 surgeons in 2 different hospitals. And that's basically what clustering is, or nesting of the data. And so we went into a whole bunch to rabbit holes of doing all these different types of modeling. We ended up doing hierarchical modeling, which is clustering, when we cluster on the service line, the hospital, and whatnot of 2 surgeons in that. And then we did smoothing to kind of look at across sample sizes. Because if you have 1 complication, but you only have 2 cases, and you rate by to 50%, it's probably not 50% if that person did 10 cases or 50 cases or 100 cases. And how do we figure out to do that adjustment for sample size? So we did all of these things to look at comorbidity risk assessment of the patient, because we know that all patients are different, and some have a lot of comorbidities, some have little. Case mix adjustment. So a hospital might just do all primary 15-minute biliary colic gallbladders, and another hospital might be doing esophagus and pancreas and emergency colon operations, and so the complication rates are going to be inherently different there. And then all hospitals have different sample sizes. So some hospitals do 300 cases a year, some hospitals do 30,000 cases a year, and how do we fairly compare all those things? So we did a lot of papers like this one to look at risk adjustment and shrinkage adjustment, which is the sample size, and case mix adjustment, which is the procedure mix adjustment, to look at those things. At the end of the day, we wanted to know, do hospitals who take care of the sickest patients, who have small sample size, who have a really difficult case mix, are they unfairly graded? And as much as we can evaluate this, and it's kind of, we tried to poke holes in everything we did to make sure that we are being fair, and the answer was no, they're not being unfairly graded. The patient procedure adjustment methods were reliable, even for hospitals with the sickest patients. Now, you can imagine that somebody collecting data, let's say you're going to do a chart review, and then you have to collect 300 variables. Like, that's awful. And we understood that. And if you can only collect 100 variables versus 300, who's not going to want to do that? And so when you do modeling, you can model, remember the regression is basically an equation. You could regress and have 100 predictors, you can have 50 predictors, you can have 5 predictors, and the prevailing thought is like the more predictors you have to risk adjust, the better your estimate and the closer your estimate. Well, we did a paper that says, well, we can select 25 adjustment factors, but if we select 7, the correct 7, about 7, we can get the same answer. We could get the same risk adjustment. And so a more parsimonious model was not just as valid, it was much more feasible, because then the data collector only had to collect 6 or 7 variables per model instead of 25. And so that makes a difference, because that gets into a lot of things that you will see over and over again in your lives. You want validity, but you also want feasibility. And so this is what we're trying to do in terms of like, well, how is this going to work on the front lines, not just to write a paper because we can put 300 variables into the model, but if we can use just 7, then suddenly it makes it a lot easier for the people collecting data. And then maybe they can collect more cases because then a bigger sample size is always better. We reverse engineered how we do risk adjustment so that we can predict. And I don't know if you've all seen the risk calculator, but we then kind of tried to do the risk calculator to say that, all right, if we take all the variables that we know before we get to surgery, what is their risk of whatever complication? Mortality, SSI. So the risk calculator, and at the time, we thought that this was so important that we just gave it for free. So it's outside the paywall, it's continued outside the paywall. Our CFO is constantly asking me, can we charge for this? I'm like, no, this is really important. There are hospitals that can't do NSQIP because they can't afford it or they don't have whatever and wherever around the world. And whenever I travel internationally, I hear about people using the risk calculator. I was just in Australia a few weeks ago, and people in the Outback, wherever that is in Australia, I'm not sure where that was, but they don't have NSQIP. They're saying, and these anesthesia people in the Outback are saying, we love the risk calculator because we can get it no matter where we are, with kangaroos hopping outside our door and whatever they're talking about. And we can use it to help risk estimate our patients so we know when to worry, when to worry more, worry less. In this day and AI, we kind of started to ask, well, can we use machine learning, and will that be better than when we have our statisticians kind of do the evaluation? And yes, the discrimination is slightly better, but this is the number. The area under the curve for the regression is 0.825, and with machine learning, it's 0.829. So it's slightly better. It's probably not going to matter so much when we kind of think about it clinically, but we try to do our homework and put it out there for people to kind of like or not like. At the end of the day, these are 10 papers that, not the most important 10, but these are 10 good representative papers of things that we wanted to do to ensure validity as well as feasibility of the data when people started using this data. Because we want to have, if we want to have quality, we need to know what's believable and what's truth versus the fake data. After we put that data out, people, and even before that, people, when they were joining NSQIP, they said, you know, what we're getting in NSQIP is very different than what CMS or the private payers are telling us. And we said, well, it's because it's code data. And so I think that, I mean, all the faculty know, but the residents, when we get paid, how do we get paid? I dictate some that, and then we have our stuff in the electronic health record. Our hospital has coders that code what happens in the care and submits that claim to a payer, whether it's CMS or a private payer. The claims and the codes are called ICD codes, International Classification of Disease. Come on, somewhere in Switzerland, it's this world kind of community. They kind of decide what's a code, and then what's the definition. We submit our claims for procedures by CPT, which is, interestingly enough, owned by the AMA, and they make a lot of money because we all use CPT codes. When payers want to evaluate quality, they use coded data by the ICD and CPT codes, and it's by the definition that is made in Switzerland. When we started putting NSQIP out there, hospitals said, wait a second, you know, CMS tells us our SSI rate is this, and you tell us our SSI rate is something different. What gives? Why can't you all get it together? And when we tried to look at it kind of in a very empirical, kind of like non-formal way, we saw that there were differences. And we talked to CMS like, coded data is terrible. You should use clinical data. And they said, no, coded data is good enough. So they agreed to do a study. So they funded us to do a study together. And in fact, 2 of the authors here were directors at CMS at the time. And so they gave us data to merge It was about 100 hospitals. It was like 100,000 patients, where we had 100,000 patients and we had NISQIP data and we had the claims data from CMS. They opened up their kind of data chest and we were able to merge 100,000 patients. And this is one of the tables that kind of set it straight for them to kind of see how different this was. So in this blue box, this column is basically a sensitivity analysis. If you take 100 people who had an SSI, and I'm using SSI as an example, you can see all the different complications there. And this is more than, we had more than what was in this table. If you take 100 patients with complications like an SSI, 100 patients who had an SSI by NISQIP, right? We definition, we had the integrated reliability. We were sure these patients had SSI. How many SSIs does CMS think there are? If we knew there's 100 by truth, by clinical data, and if we look at SSI, they think that there's 30. For every 100 people that had SSI, they think there's 30. So they were undercalling it. That's a problem, right? The first slide of inaccurate data, you don't think there's a problem, or you think it's a third, it's 30%, you have 30% of what the truth is. That's a problem. If you look at the red box, which is false positives, this is how many, if they say there you have 100 SSIs, how many are false positives? 48%. So it's almost double of what it should be. So there is just inaccuracy of the codes of SSI. If you look at pneumonia, same thing. 50% sensitivity, so you're only identifying 50% of pneumonias, and the overcall or the false positive was even worse at 60, it's almost 2/3, 63%. As soon as we showed this to CMS and we did it together, these are the results. We had like all these different statisticians doing this. And I'm like, well, we need to do something different. But the problem was that NISQIP was not in the 5,000 hospitals that did surgery. It was in 700 and so forth. And it never became, so this is a valid study. It shows the validity of clinical data and the lack of validity of claims data, of billing data, but we didn't have the feasibility part. It wasn't feasible to use NISQIP or clinical data on all hospitals this was done in 2008, 2009. It wasn't feasible. And so that was a lesson for us. Like, we need both validity and feasibility. We didn't have the feasibility. So consequently now, CMS still uses coded data when they measure us. And it's not as accurate as clinical data, but this is the only feasible way that they can benchmark all hospitals in their star rating system and all these other things. So this was but this is where we are with clinical data and claims data. When you all get data that's measured on you, your hospital, your service line, your whatnot, it is usually with claims data, and claims is the same as administrative, the same as billing data. That's all the same. So watch out. Just know what data is being used, because it's very important. And you can see the agreement is usually important. For the hospitals who use NISQIP, early on we asked, well, does this really make a difference? Are hospitals getting better? And when we showed very early on in the first few years that most hospitals improved their complications and most hospitals also improved their mortality, these types of cases that are that we collected in general, mortality wasn't a huge event rate. It didn't have a huge event rate, so it was very hard to have all hospitals improve that, but most hospitals improved both. When we first presented this was the first paper at the American Surgical one year. The first person who stood up in the audience and said, "That's how do you know that this is not regression to the mean?" And so everyone remembers from stats, regression to the mean is like, you measure something, there's kind of good and there's bad, but the next time you measure it, the bad gets worse and the good gets better. How do you know that these aren't just these bad hospitals just getting better? So we did this study. I'm not sure we ever published this, but remember the caterpillar graph with the red and the green hospitals. So here there's 8, and there were 8 outliers in the red, 8 outliers in the green. If this is regression to the mean, then the red should get better and the green should get worse. Well, we looked at the red first. In 2006, kind of 7 of the 8 got better in 1 year, and then they continued to improve. So that could still be regression to the mean. So we looked at the good outliers. Of the 8 good outliers, 1 got better the next year, but then 7 of the 8 got better 2 years later. So it was actually moving of the curve towards the green. Everyone was getting better. And this kind of makes sense that no matter where you are on the curve, there can always get better. We have not seen somebody who has a 0% SSI rate and a 0% pneumonia rate or whatnot, so everyone can get better. And that's kind of a theme of this, is that it's continuous. The outcome over many years, when we looked at it, things continued to get better over all the hospitals, even though hospitals were continuing to join. The top line is mortality, but more bigger slopes were in morbidity, and SSI is the dashed line. And if I break up all the morbidities or the complications, you can see all the individual things here. Once people know what their rate is, once people know that places are in the green, they're not in the green, there's always this movement towards getting better. I'm going to blow by these next 2 slides. It saves money. This is a collaborative in Tennessee where of 10 hospitals, they saved a couple $1 million, and this was important for them to look at because private payer was paying for this. And in Canada, this is in Alberta, that they saved, and this is in Canadian, $8 million. I don't know what that is in. Is that like $4? I don't know. But what they said is that their investment ratio every dollar in NSQIP brings back $4. And that's the ROI of having good data. Having good data lets us know where we are and lets us know where to improve. Now, I blew through that, but NSQIP, and we started this in 2004, as I said, but once we kind of got some good results, and once we know that we could do validity and kind of some feasibility in terms of the individual sites, there were some offshoots of NSQIP. So somebody mentioned TQIP earlier. After about 6 or so years of NSQIP, Avery Nathans, who's a trauma surgeon who in Canada but works at the college, said, "Can we do this in trauma?" So we developed TQIP, we developed pediatric NSQIP for the kids, and then bariatric kind of did its own thing as well. We have offshoots, so EGS has part and a geriatric thing and whatnot, but they're all basically this idea of NSQIP of getting clinical data. Having said that, strategically at the college, when we're trying to get all of surgical care in the United States better, raise the tide, lift all boats, all that kind of stuff, we take into consideration something we also believe necessary. And that's the Donabedian quality model. So you've probably heard about these terms: structure, process, and outcome. Outcome is the result we get. We think about outcomes all the time. How do we get good outcomes? We do the correct process. We take them to the OR, we give them TXA, we do X, Y, or Z. We do the right process. And how do we do the right process? We have the right structure in place. And structure, you can think of resources, whether they're kind of machinery resources, like using having a CT scan. If you're in a hospital with a CT scan versus without a CT scan, that's a structural difference. And there's probably better things with the CT scan if you have a CT scan in place. The 2 common resources in structure, and 2 probably most important things, are people and time. And to have enough people, somebody was mentioning the nurse staffing ratio is a structural variable. And if there's 1 nurse for 40 patients, that's different than 1 nurse for 10 patients. And so that's an issue. And do they have the time to do that? And they're very kind of integrated. But this idea of structure, process, and outcomes helps us understand how we should take care of complexity. And so I want to spend a few moments in terms of complexity. So we kind of divide the world into simple, complicated, and complex. And so we kind of use some of these words interchangeably, but I want to give you an explanation of at least how we think about it at the college. So simple is like baking a cake. Baking a cake where the recipe or the protocol is essential, unless you do it for a living, you just have it memorized, but having protocol is important. The protocols or recipes are usually tested to assure that the reliability, you get the same cake every single time. A single individual expertise is good to have. So whoever is doing it, if they're an expert, you're going to get a good cake at the end of the day. And every project is probably pretty much identical throughout, right? You make a cake, good. You make 2 cakes, good. You make 2 cakes a week from that same recipe, good. So that's simple. Short recipe, I don't know, 7 steps, few ingredients, and so forth. Complicated. Complicated, the example here is like sending a rocket to the moon. And in this, rigid protocols or formulas are needed. And one success increases the likelihood of the next success. There's high levels of expertise required and different teams. So there's a protocol to figure out how to build the rocket. There's a protocol how to thrusters. There's a protocol for how to kind of bolt on the door. There's a protocol to figure out the weather and where the moon is so that when you take off at the right time. There's all these protocols, and every project is largely similar with some small individual differences as technology advances and whatnot. There's probably, the other example might be building an airplane, a 787. It's not simple because there's multiple protocols, and each protocol, I mean, combined together, like maybe a million steps. So it's not as easy as baking a cake, but there is some level of reliability there because the instruction sheet is the instruction sheet, whether sending somebody to the moon or building a 787. And they're relatively safe. That's complicated. It's achievable. Complex. Complex is the one we fall down on. Complex, for those of you who have a child or were a child, or those of us that have pets, complex is like raising a child or raising a pet. There is some level of unpredictability. And so rigid protocols might be helpful. They might have limited application, or they might be counterproductive. For those of you who have more than one kid, like your first kid, you do one way, came out good, and you kind of raise the second child the next way, it could be totally different. Same thing, we have 4 dogs, and yeah, it doesn't work. One success provides experience, but is not a guarantee of success of the next. Expertise helps, but it has to be balanced with responsiveness and adaptability. If you are in the business world, agility, the agile kind of ways of doing things. And every project is pretty unique and must be understood as an individual. This is really healthcare. This is, 3 patients that were presented this morning are all different, that we all kind of took care of from the surgery department, but they're all different. And there are some levels of things that were unpredictable, that were not against us. It's not like baking a cake or even building a rocket. And so when we get the results here, outcomes are certain or guaranteed in something simple. There's a high degree of certainty of outcome in something that's complicated. There is some level of uncertainty in outcome. And that's inherent in something that is complex. Complexity has a level of unpredictability. We don't know. No matter how much math we do, no matter how smart we are, no matter how many YouTube videos we watch and how many textbooks we read, there's some level of unpredictability. How do we get good care when it's complex? How do we give great care in the trauma setting where you have somebody bleeding in the bathtub for who knows how long, who knows what their blood loss was, who knows what their brain function is or whatnot? That's the level of unpredictability. So there's a simple graph that when we look at agreement and certainty in terms of simple, complicated, and complex, where when something is simple, there's usually high agreement in what to do, and there's high certainty of what the results are. And the further we go out on the curve to complexity, there's less agreement because we have less data, and then there's less certainty. When things are complex, when things are simple, let's start with there. The key ideas, or the way we should think, is that we should standardize. This is a simple thing we should standardize, whether it's baking a cake or it's a simple kind of procedure, and we should have protocols. We should have simple KPIs, key performance indicators, because it's so consistent and highly reliable quality is achievable. You like straightforward things. I don't know, when I do a hemorrhoid, that should be pretty straightforward. Not always, so you have to know how to do it, but it's just pretty straightforward, and we can pretty much predict what's going to happen. For higher complexity, key needs are: 1, a foundation of structure and process. Remember the Donna Median model. We need to have a foundation of resources, and we need to be doing the right thing. But the second thing is we need data that's accurate to have assessments and to know our outcomes. And we have to have it in almost in real time to have the adaptability to be actionable. So we're doing it on a base of structure and process of the Donna Obedient thing, but we have to be agile when things don't come out or when we discover things along the way, like the 3 patients that we saw in MM. So we developed programs at the college called verification accreditation programs that are based on these 4 pillars: standards, the right foundation, data, and verification. But the right foundation are the structure and process things. The data allows us the outcomes and to be having that adaptability. And so these programs, these verification programs like the trauma verification, so level 1 trauma centers have this in place. Commission on Cancer hospitals have this in place. We have a number of things, and actually these are a list of some of the programs that are accreditation verification programs. And these are all built on those 4 pillars and having structure, process, and outcome. Doesn't work. So this is the manual for the trauma program, the resources for the optimal care of the injured patient. And so in the face of complexity, and I don't know many more complex, higher complexity things than trauma care, this is a study evaluating trauma care in trauma centers versus non-trauma centers. It was published, it was done by a group at Hopkins, and it was published in the New England Journal several years ago. But if you look at the most injured patients with a maximal injury severity score, you can see for death in the hospital, death at 30 days, 90 days, and 360, there's a difference in death rates. And so actually, when you have the structure and processes in place, the outcomes are better for when there's a level of unpredictability in trauma centers. So a good outcome in trauma is mortality. And so mortality can be different, and it is different when you have those standards met and the structure and processes in place. In bariatric, now there's less and less bariatric surgery, but before it was kind of the wild, wild west. When bariatric first started, people were operating on these. It wasn't standardized, and patients had a lot of comorbidities, and they were very large. But you can see that in accredited versus non-accredited, there was a difference. And the places that were accredited followed the standards, had structures and processes in place, and had better outcomes, both in terms of money, in terms of lower complications, lower mortality, and they had better rescues. FTR is failure rescue. And then breast care. This is another example. And I could go through all of our programs, but I just did these 3 just to kind of give a variety. Breast care is difficult because, number one, the protocols are always changing. They're finding newer and newer ways. But also breast care is very difficult because the location of what the pieces are so varied. They will, more and more it's getting to outpatient care. There's a primary care doctor. There's chemotherapy over there. There's radiation someplace else. There's all this other stuff someplace else. And so how do you coordinate care when it's so difficult across many different locales? It could be different systems, obviously different doctors, and so forth. And so it's a complex multidisciplinary disease. If you look at these things in red, and these are just some abbreviations, but it's basically the performance measures for breast care, giving tamoxifen or aromatase inhibitor if it's HR positive, chemo HR negative, more than 4 nodes, radiation, all that type of stuff. And these are well known by all breast surgeons. And yet, when they are in a program that follows the standards, these are better done. So having better structure and process in place and following these standards gives better kind of care to breast patients, even though everyone knows what the rules are and what the performance metrics are. This is, I don't know how old, this is like 5 years old, but these are the number of sites in the United States that participate in one of these accreditation programs or the registries or both. And what we try to do at the college in the quality division is raise the tide, lift all boats of all the care that is happening in the United States, and how do we help all of these hospitals give better care? And this is one of the ways. There's more. There's a whole education division that helps people learn, X, Y, and Z. But these are the quality programs in the United States. Now, I want to get back to NISQIP because this is going to be really relevant over the next probably 3 years, I would say. In NISQIP, we have accuracy, we have clinical meaningfulness, and it's risk adjusted. But there is a delay, and so we do not have real time, and we do not have all cases, because even though sampling is statistical, surgeons will say that, well, you just selected my hard cases, you didn't get, um, so it's not fair, you didn't get all my cases, and so forth. So that's where deficits were. But with technology, with better chips, with better ability to get into the EHRs, what we're working on right now is automating the data out of the EHR. So in the college of surgeons, of the 4,000 sites, 70% of them use Epic. So we signed an agreement with Epic last year to start working on dumping the data out of Epic, which is that for this arrow. Ooh, this arrow, and then onto the college platform. The college platform is then used to kind of put the data together, do the stats, do the machine learning or whatnot to get all the data. This will get us all the data in the EHR. And what that allows us is that when we were talking earlier, man, I wish TQuip had X, Y, or Z, or we constantly wish we got more variables in this quip. But we try to keep the parsimony for the data collector. Now we can get the whole record dumps down in 100% of the patients. And so now we can start to see in even more granular picture of what patients are getting, what we're doing with patients. If we want to know how far they walk, we read the nurse's notes. If we want to get eyes and O's, we can read that sheet. We don't get that now in most of our records, but in SQUIP or TQuip, but we're going to get that soon. And so this is what the new registry is going to look like. It's going to get automated. It's going to get all this data. It's still going to have to be done well, because we can certainly do terrible statistics and do terrible things with terrible data, and I suspect some will. But kind of learning our lessons with NISQUIP over the first 20 years will inform how to get validity out of this data now. And so what do we get from this? We'll get more outcomes. And what I would really like to see is more processes. So we've done studies where places have said, yeah, we do ERAS. We've had ERAS in our hospital for the last 10 years, and yet they have bad outcomes. We got grants from ARC for many millions of dollars to kind of go into these hospitals to look at how well they're doing ERAS when they say they do ERAS. And we started to measure the compliance of each step of ERAS, and there's usually about 10 or 12 steps. They're walking, they're eating, they're drinking post-op day 1, and all the stuff that's done in the OR, how much fluid were they, all these types of things. And most hospitals were doing much worse than they thought. And I'll give you an example at UCLA. We write, walk the patient out of, starting on day 1. And I said, yeah, of course they're getting up. And when we looked at the data on an audit to actually look at how many patients were getting up, it was about 10%. So I thought that our patients were getting up 100%. I wrote the order. The residents were telling me that they were getting up. And when we had somebody actually kind of looking at the chart and actually somebody sitting there with the patient, it was about 10%. If we start to know what our processes actually are, we can do process improvement to get the better outcomes. And so we'll have more processes, and we'll have more data insights, like all the medications and pathology and radiology, implant ID, so we can follow the matching stuff for term. And time variables. It seems like every hospital is working on FCOTS for case on time starts. Terrible at all hospitals in the UCLA system, and so we're constantly working on that. But part of it is just like, do we believe the data? Because they have some auditor out there with a clipboard trying to look at things, and I'm not sure that that person is doing a good job. Anyway, this is, I know you're in NISQUIP and getting data through the college, but this is going to be unveiled next year. And so I think that this is going to be really helpful for us as we're kind of going forward in our evaluation of quality. So we'll be able to survey better. We'll be able to evaluate better. For the residents who want to do a research project, you'll have all this data de-identified, but you'll have this to explore all the questions that you want to ask. And then when you get those things, you can act on it, either with quality improvement projects or more research. Finally, we want all hospitals to be on green. You've heard about all the kind of flow sheets and all the kind of scorecards, and there's green, yellow, and red, just like a stoplight. But we look at this differently. When we visit hospitals, there are hospitals in the red who don't look at the data. As people heard that people were getting better in NISQUIP, the hospitals signed up but didn't act on it. They didn't even look at their data, because when we send it in some of our programs, we know if the file is open. Like you can see if an email or a text is open. We knew when this email was opened and when they access their data. There are hospitals that pay somebody to collect the data. They pay the college to analyze the data, and they don't open the file. That is, I just tell them, like, you should not be in NISQUIP. Our CFO hates it because, it's a revenue source, but they shouldn't be in it if they're not going to look at the data. But these are these red hospitals. Their kind of numbers bounce up and down, up and down. It's like they didn't look at it. They didn't look at it. The yellow hospitals. The yellow hospitals, I don't know if you've ever seen this, but these are hospitals, they figure out a way to do it, and that's the way they've done it. When I visit hospitals and they do something really old-fashioned, like, oh, how did you come to this? He's like, oh, I was trained this way, and my mentor was trained that way, and it worked, and so we constantly do it that way. That's, at least they standardize, but there are ways to get better. And that's the green hospital. The green hospital continually improves. They improve once they figure out a better way of doing it. They standardize it, so it's in the drinking water, and then the data shows them that there's opportunity, or even like the nurse manager leaves in the OR, things change. You get a new scrub team, things change. Somebody joins the practice, or somebody leaves the practice, a surgeon does, things change. And there's an opportunity to reevaluate, innovate, and improve again. And constantly, when the data shows that you've gotten better and you've kind of realized your gains, then you standardize. That green is not so easy to do, but when we see hospitals that do it, it's like music to our ears. When you see that, it's kind of like, I don't know, when one of our kids would say, I'm going to come home and do my homework first instead of play on the computer. Like, it's music to your ears. When we see a green hospital like this, it's music to our ears. So we would love all hospitals to be green, and that's the CQI, the continuous quality improvement. I put this here. I know that Patricia Turner was here, and I always want to end on this, what the mission statement of the college is, and it's to improve the care of the surgical patient. At the end of the day, we try to do the best we can in surgery. We have to work with anesthesia and the nurses and everyone, pharmacy and everyone we work with pre, intra, and post. But when we think about the surgical patient, what they go through before the operation, during the operation, after the operation in the hospital, and particularly post-discharge of what they're going through. Because some people think like, oh, they're out of the hospital, I don't have to worry about them anymore. Well, we're taking care of human beings. And when they get back and when their trajectory is afterwards, what is their trajectory? What did we promise them they would get after the operation? And are they actually getting it? I suspect that, remember I talked about age-friendly and what matters? At some point with technology, we will be able to, and probably with ambient listening and all that, we will talk to them and they say they want to have whatever, quality of life, and they don't care 7 out of 10 pain, or they want to not have as long as, not that long, but they want to have 2 out of 10 pain. Whatever it is, we will be able to measure it afterwards. And we will start to have a metric that will allow us to say attainment of their goal. Whether it's quantity of life, quality of life, or something in between. And we will not be measured by a mortality rate or an SSI rate. We'll still have those because we want care to be safe, but we will have goal attainment for the individual patient. And people who can get goals of their patient, whether it's quantity, quality, whatever the patient is saying, will be the providers who kind of will be the better providers. That is probably coming into play with all this data and so forth pretty soon. So I'm going to end here. Hopefully you kind of get a sense of what goes into what accurate data are, and this idea of complexity and unpredictability, and how do we address unpredictability in our healthcare system and in surgery. So thanks very much. Happy to answer any questions.
Thank you so much, Dr. Ko. This was fantastic. Really appreciate you taking the time. Questions for Dr. Ko?
Yeah, that was great. Thank you so much. I did bariatric surgery for my career, so it was interesting to see you put that up about high risk bariatric surgery. But I remember it was 2004 when NISQIP started. CMS came out and said, well, in order for you to do our beneficiaries, and as you know, commercial insurance follows what CMS does, you have to be a center of excellence, and you had to report your data to NISQIP. Well, it didn't take long to figure out for all bariatric surgeons that you just didn't do hard cases. You just did all easy cases and your data looked great. And so the people that really needed the surgery didn't end up getting the surgery. And I know it's getting better now with the risk adjustment. Even back then, to me, the highest risk surgery for bariatric surgery was a revisional case, a patient that had 1 or 2 prior surgeries before. That wasn't even a question asked on that NISQIP and risk calculator database. But I know things are getting better now. And I think with Chat GPT, it should probably get to the point where for elective surgeries like that, you know, it's hard to do what the actual risk adjustment is. I don't know what you think about that.
Yeah, so great point. So for everyone in the room who's not as familiar and experienced, probably around the time NISQIP opened in 2004, 2005, early 2000s, bariatric surgery was really ramping up. With the bypass and some other operations, sleep hadn't been used yet. The mortality rate in some studies that were kind of randomized studies was 7% on an elective procedure, which is obviously really high. CMS said, we're not going to pay for people to have this procedure if the mortality rate is 7%. And then they had this thing called an NCD, non-coverage decision. They were not going to cover that patient. They're not going to pay you unless you belong to what they termed the center of excellence. And so there's different companies came out with the center of excellence. The college had experience with cancer and trauma with the standards and structure, process, and outcomes and whatnot. And so we started this and allowed hospitals to see like what went into this, because it's not just the surgery. There's a lot of there's a lot of intra, there's a lot of post in terms of taking care of a bariatric patient. There were a lot of procedural things. It used to be an open procedure. Can you imagine getting through, you know, a pannus that was this thick, and they all had SSIs because of that, and leaks and all kinds of stuff like that. So I showed you some data where accredited is better than non-accredited, so they kind of got things in order. The thing that you're talking about also is that if we skim off the top, is that a way to game the system? And initially, it is a way to game the system. Like if you only take care of, you know, 32-year-old marathon runners who have no comorbidities, take no medications, your results are going to be pretty good. If you do have one superficial SSI, that hospital will fall to the bottom of the list because they should be doing basically perfect. And so when we start to do these studies, and I don't know if we publish these, but we're constantly doing these, like how good is our risk adjustment for those places that skim off the top versus don't. The way statistics are going is that it is more advantageous to do pretty well with a sicker patient than nearly perfect, but not perfect with a skimming off the top strategy. And increasingly more, we are having value-based care where the payer will give us one lump sum for the episode of like 30 days before the procedure to 90 days after, and the days will change depending on what the payer is. But you get, so for example, UCLA will get, when I do a colon operation, we'll get, I'm just making this number up, $20,000. They get $20,000 to take care of that patient. And that patient has to, you know, and if UCLA can take care of that patient for $19,000, they make $1,000 on that patient. If it costs them $21,000, they will lose $1,000. Initially, the The idea was to take care of only, skim off the top and take care of only healthy patients. But the metrics come out so that that exactly what I said, where they rate you on performance measures. And unless you do perfectly, which is really hard because of this idea of complexity, then we usually get the whole system, the hospitals will get dinged for not doing perfect care. And nothing really ever comes out perfectly in healthcare. So this idea of skimming off the top on the idea is kind of like attractive to a lot of people initially, but the payers have figured this out, and the way the performance metrics go, it's not the advantage that we think it is. Does that make sense? I don't know if I explained that well, but it's as places figure out how to game, the payers and that side of the equation are figuring out how to prevent gaming, or how to not really have that advantage of gaming. That's about it.
Thank you very much for this presentation. This was excellent. I think the college has shown over the last 25 years, where we stand with quality today. And it is also exemplary for all the other medical specialties, because I don't think many other medical specialties are at the level of where the college is right now. Now, you mentioned we need to do more process analysis. And the tricky thing with process analysis is that we need more resources for that, because you need to do process auditing, which will be certainly critical for a complex scenario. And healthcare is a complex industry. So the question is, besides machine learning and automating, working with Epic together, who also is certainly not perfect in process auditing and getting the process data, not only the outcomes data. That's a big challenge for you. How to move best forward in that. Secondly, I think one area, and this is certainly a separate area, a separate topic, is safety and safety measures, and how to bake safety measures in the future into ACS quality data, such as failure mode analysis. And thirdly, with value-based care coming, likely in the next 5 years, everybody, each of us, will be on value-based care and purchasing. How to close the gap between the clinical data and the CMS data, because CMS, when value-based care is 100%, CMS and the commercial payers will follow, of course. They will hold us 100% to value-based purchasing, right? And how to close that.
Yeah. Okay. Three things. So let me start off kind of reorganizing those questions into this. For the residents, how do you define quality? It's really difficult. It's kind of, how do you define good, or how do you define, but in this country and in a lot of countries, they have different domains of quality. The easiest way to think about it is the word STEEP with 3 E's. The quality that has 6 domains, the way we think about it in the United States. S, safety. We don't want to kill the patients. T, timeliness. We don't want to have a waiting period that UCLA colorectal, and I get an email about this every day, is like the next appointment for a colorectal surgeon is in August, and somebody has a problem now, they don't want to wait till August. That's timeliness. We're not doing a good job with timeliness. The 3 E's are effectiveness. So like, we do a hernia repair, is their hernia fixed? Yeah, they don't have an SSI, like a safety problem, but if their hernia fixed, is their pain better? Can they walk? Can they function? That's effectiveness. The other E is efficiency. Are we kind of being efficient with our system? Do we get 3 CT scans when we only need 1? Are we ordering 1 million lab draws when we don't need any? Things like that. How efficient are we kind of going through? There could be other efficiency things. What's our kind of turnaround time for our cases? When I was at UCLA, before I went to my residence for my fellowship in colorectal, the turnaround time at UCLA was 2 hours. We could go into Westwood, have lunch, come back, still, read the newspaper, watch TV, and then the next case would be ready. I went to the Leahy Clinic, and I just assumed everywhere was 2 hours. I missed my second case on my first day of fellowship because the turnaround time was like 19 minutes, and they did the case without me. I was like in the doghouse at Leahy for like 3 months. But that's efficiency, and UCLA lack of efficiency. And I use this as an example because that's where I work. The third E, effectiveness, efficiency, is equity. Are we telling, is there fair care for everyone and it doesn't matter what your wallet size is, it doesn't matter what your skin color is, it doesn't matter what you live or whatnot. Do we have equity? Do we have equity within UCLA? Do we have equity in California? Do we have equity in the United States? So that's a third E. The P, the steep P, and this might be one of the more important ones, is patient-centered. Are we getting the patient's voice when we kind of figure out what quality is? Mr. Smith, what do you think? And we kind of get that in the experience. There's something called the CAP survey, where hospitals send out a survey to the patients every so often, and nobody puts stock into that. The response rate is usually below 10% for that. But we should get the patient's voice in what we're doing, and it overlaps probably with effectiveness if we ask them like quality of life and so forth. That's how we think about quality. And to your point about safety, care should be safe, but it should also be all of those domains as well. I suspect, kind of in also answering your question in terms of claims and clinical data, because of things like ChatGPT, because of the better chips, because of more and more electronic data, we will get so much more data on what we're doing that that we will not be hindered by using only claims data for evaluating quality. And that will also include processes. And so it's very hard to get process improvement, as he was saying, that the only way we were able to get process improvement for the 10% walking ambulation rate for a user is having somebody sit there. And that's, yeah, we could pay some college student, $1 a day or whatever we pay them, but it is just a human being doing that. Can we do that better efficiently if we had cameras in the hallway, if we do, whatever it is, to do that with technology? And we will be able to. And I think that is what we will see. And then we will start to get those things. And then when it comes down to the value-based care, when we get $20,000 to do a colectomy at UCLA, and that pays from 30 days before to 90 days after, we will be able to, see where our deficits are much better than that. We know that when we're getting the data from Epic, and these are the things we're doing in the back rooms of the college now, we can divide the world into structured data, like labs are structured, and things in menu-driven are structured, and there's unstructured data, like the free notes that we type in there, that we type, the nurses type, and whatnot. We can use natural language processing, just the same thing we can use ChatGPT to summarize something, and we can call out really good data that way. So we can call out from the op note, and we can get what the CPT code should be, depending on the dictation of what that is, without kind of figuring out what somebody wrote as a CPT code. Because when we have, the nurse in the back of the room write down the CPT code, it's frequently wrong. We have to redo it anyway. We found that we can use natural language processing, which is basically ChatGPT, to kind of figure out what the right CPT code is. I suspect that we will get better at that, and then we will have ambient listening instead of me typing it, because I type really short notes and I probably miss a lot of stuff when I type. So we'll have ambient listening, putting that in, and we will have more video monitoring. And you probably all know the video monitoring going on in the OR right now. Intuitive is working on this, private companies are working on this, where they can get a video of our surgeries and tell us that you didn't look at the critical angle in that gallbladder, or you didn't identify the ureter in that left handling, or whatnot. And they can start to grade us just based on these pictures. So that's what's coming. Both good and bad. It's bad if it's used the wrong way, but that's why I wanted to kind of give you a sense of what accuracy and rigor really means in terms of data, because not all data are the same.
Excellent question. Before we close, what advice do you have for faculty and learners?
Yeah. So I think the big thing that I come away with is that healthcare, while on the one hand is a business and people have to stay in business to give care, at the end of the day, quality is going to rule what we do. And if we don't pay enough attention to quality and only go for the business aspect, our field will be sorely hurt. So wherever you're working, whether, the place believes in kind of being a green hospital or not, you as an individual, and this is the professionalism that I think is best in surgery. I'm clearly biased, but I do think so during the kind of visiting lots of hospitals, seeing across many specialties. That individual professionalism and integrity that you all have, that you are getting trained to do, like at M&M like this morning, that will serve you well to continue being like that your whole career. Probably goes outside your career as well, but within at least surgery, having that level of professionalism, integrity, will serve you well the rest of your career.